But so I know that you had a number of questions. I don't know how we should do this. There were, you know, if anybody has a pressing topic, I can tell you some of the things, you know, that we've talked, that people have asked questions about. I don't know if we should have people introduce themselves, maybe to who's on and can tell us where they're from, what, you know, what part of the country or the world they're from. That would be great too. So let me go ahead and discuss. I had posted on the website, just because I know somebody asked a question about this. We posted on the website this interesting paper, you know, that was just published in a neurology journal about a new model of autism that was developed involving mutation of the CAM kinase gene, CAM kinase 2, right? Now that is very exciting because it may be a potential link between some of the things that are being studied in pandas and some of the things that are being studied in autism. Now, I don't know how many of you out there know about the Cunningham test or very familiar with it. Maybe your child had that test, but let me explain what the first part of that test is all about, right? It's really a test entirely about autoantibodies, right? So you've maybe heard me talk, and we'll talk a little bit more about the two phases. We think of two phases of pandas, a cytokine phase, or early fever phase early on, and after multiple episodes of infection, it sort of evolves slowly over time into an autoimmune disease. And when that happens, you have autoantibodies, and the treatment of pandas has to be different. Well, I don't know if we're back. Okay, good. So when we're thinking about the Cunningham test, its main use in treating and evaluating children for pandas is to determine if a child is in the autoimmune phase. And it's actually a very important question, you know, because sometimes we have kids that have had symptoms for a long time, or we've been treating for a while. They seem to at first get better with the usual treatments of ibuprofen and antibiotics, the way we would treat a fever in short, but after a while it doesn't work anymore. And we have to wonder if they have in fact gotten into this phase of the illness. So we do the Cunningham test. And one of the there are two parts of the Cunningham test, and one part is measuring the ability of your child's serum, or the subject's serum, to activate this enzyme called CAM kinase 2 and CAMK2. And that enzyme is a very important signaling enzyme in the cell. It's called calcium calmodulin dependent protein kinase 2. So it's a big mouthful. And if you break it up, it's calcium. Just, we know what calcium is. It's a very important mineral in the body, but also inside the cell, extremely important in conveying messages inside cells. There are calcium channels that specifically allow calcium into cells, and it comes out of various compartments of the cells, including mitochondria. Calmodulin is a very important molecule, a very old molecule that goes way back in evolution, which mediates a lot of the calcium effects. In this case, calcium binds to calmodulin and activates this enzyme called protein kinase. The word kinase, K-I-N-A-S-E, the K in the CAM kinase thing, means an enzyme which phosphorylates or put a phosphorus group on another protein. So this phosphorylates a bunch of proteins. And in this, and by phosphorylating proteins, it leads to the conveyance of a signal. So you can think of it almost like the way the cell works is that there's something on the surface of the cell to receive a message from the outside. How does a cell communicate to the outside world? There's something on the surface of a cell, which we call a receptor, and that has to then convey the message to the interior of the cell. And that occurs by sort of like a bucket brigade, where one thing is passed on like a relay, one thing to the next, one thing to another. Well, many neurotransmitter receptors signal through CAM kinase. And not just dopamine, which we know about in the Cunningham test, but many other receptors as well. And what they usually do is they activate this enzyme so it starts doing its thing. So you can think of it like imagine you had somebody at your door ringing the doorbell, and you have a way of finding out by the sound of the doorbell what is at the door. And that's how we call a second messenger works. And calcium calmodulin CAM kinase 2 is a very important second messenger. So the Cunningham test is telling us about by what it's measuring in the CAM kinase part of the test. The lower bar on the report is the degree to which the child's antibodies activate CAM kinase, and that means it's translated into what I just said. That means that it's telling us about the presence of autoantibodies against neurotransmitter receptors that signal through CAM kinase. That includes dopamine, but many other receptors as well. So in short, a positive result on the CAM kinase test indicates the presence of an autoimmune encephalopathy. So no matter how you get there, autoimmune encephalopathy seems to have a common denominator in many cases of activation of CAM kinase, or perturbing the CAM kinase system. And it produces behavioral changes characteristic of autoimmune encephalopathy. Now, the link to this paper that just came out, so that's been known. What I just told you has been known for 10 years, and that's the work of Madeline Cunningham and her group in the development of this test. This new paper shows that by modifying specifically the CAM kinase gene so that you have a mutant CAM kinase, you can develop animals that have or actually, I guess it's rats or mice that have all of the features of autism, basically. So that implies that perturbing this system kind of has a final common denominator in terms of the way it is. It's very interesting because one thing, if you have ever worked with children with autism, and to some extent kids with PANDS, no matter how they get there, interesting thing about kids with autism is they have lots and lots of different mutations. But no matter how they get there, there seems to be sort of a similar look to them. They have similar features, clinical features, in terms of, the way language is impaired, their social interactions, etc. So it's almost as if there's sort of like it all kind of funnels into one thing. And this is one such type of pathway that may be important. There's another pathway that I'm very intrigued about, too, called mTOR, M as in Mary, T-O-R, that also seems to interact with the CAM kinase system. We have some patients with mutations in those genes that have PANDS as well. So we think that there are kids that have, so it looks like there may be a convergence between some of the research in these two fields, which is very exciting, and you could then ask, okay, if we take these mice now with mutations here and we give them infections, sort of adding, infection to the model, will that make their autism worse, or will they be able to, So I think, and then understanding these pathways and then being able to pharmacologically modify them is really exciting. So it's possible the CAM kinase test is going to be a lot more important than we thought, and it's going to be applicable to more diseases than just PANDS. So I don't know if I don't know how we should proceed here. Maybe. Okay, they had other questions here.
Well, this was about the article. I don't know if you
Yeah.
what it says.
Okay, so the other questions people have: if a child has a positive Cunningham panel, can it be anything other than PANDAS PANS? The answer to that, I believe, is yes. It's not specific for PANDAS PANS. It really is telling you about the presence of an autoimmune encephalopathy. That would imply that your child is making antibodies against neurotransmitter receptors. And it's possible that a lot of us make antibodies against neurotransmitter receptors, but the research that Dr. Cunningham did suggests that that's unusual unless you have clinical symptoms. Now, patients, when they did their study, they were looking at patients with PANDAS PANS. And It's very likely, in fact, there's evidence, by direct evidence that other diseases like NMDA receptor encephalitis, etc., may also give positive results on the Cunningham panel. So it is helpful in determining whether you have an autoimmune encephalopathy, but it doesn't necessarily mean it's strep or similar to PANDAS PANS. Now, PANDAS PANS I think of as something that is it's a process that slowly evolves into autoimmune encephalopathy. So it's not something that happens overnight. It takes a while. Whereas there are versions of autoimmune encephalopathies that are pure molecular mimicry. I mean that, a bug, an infection comes in, you make antibodies to that infection, and right away that is in the autoimmune phase immediately. There's no waiting time, So that happens with a number of different things. But PANDAS PANS seems to be something where you can, by treating it early on, you can prevent progression to that phase where it gets harder to treat. Okay. So I think, the important message is the Cunningham panel is a very useful test. It's not a test that, it isn't, and we don't have a test that support, 100% is definitive for a diagnosis of PANDAS PANS. It isn't like a chest X-ray for pneumonia that, you can, listen to somebody and do a chest X-ray. Even a chest X-ray, let's think about that, right? You're short of breath, a doctor listens to your chest, and he hears poor breath sounds, does a chest X-ray, and it's normal. Your diagnosis is still pneumonia. It's nice if the chest X-ray showed something because that would support the diagnosis of pneumonia. So pneumonia is really a clinical diagnosis. The doctor says you have clinical pneumonia. I think you have pneumonia. I hear something in your lungs, and you have all the symptoms otherwise of that, and I'm going to treat you for pneumonia. Well, PANDAS PANS is similar. It's a clinical diagnosis, at least at this stage, until somebody develop, maybe one day somebody will develop a magical test that's 100% accurate. But like most diseases in medicine, it's clinically based. And then, we try to develop tests that will predict the presence of this or support that diagnosis. And the Cunningham test is really one of those tests. I think it supports a diagnosis. Because the next question is, it is said that the PANDAS PANS diagnosis is clinically based on a list of criteria. If the child doesn't meet the criteria but has elevated Cunningham, what should be done? Well, let me tell you something. The criteria for PANDAS, whether you go, PANDAS PANS, and I think many of you out there are aware that, you can look up online and see this list of symptoms, which comes out of the so-called NIMH white paper of the meeting of 2010. Those symptoms, I can tell you by being there and seeing a lot of patients, are somewhat arbitrary, okay? They were basically voted on by a bunch of people. So it's like, that's not really a good way to determine the nature of an illness by a vote. But sometimes with clinical criteria, so we can all speak the same language, we have to come up with something or a score. Now, if a child, I can tell you, we could either choose to make the criteria extremely narrow, like you have to have exactly these criteria, we can't put this name on it. And that's one way to proceed. And by doing that, we'll have maybe purer cases. They'll all look more like each other, and that's very good for research studies. But in the real world, we want to help kids. Well, what if a kid doesn't have, we've had kids, for example, that had pure tics, no OCD. What about that? I mean, is that still PANDAS? The answer is, I think, absolutely yes. It doesn't have to have those criteria. It's this, I would say, a better diagnostic criteria, or it should be considered, or testing should be pursued if a child has a sudden onset of any neuropsychiatric symptoms in a previously healthy child. So it could be a range of things. It's usually OCD and tics and, decline in handwriting or something like that. But what if it's psychosis or something like that? Would that throw it out as as a thing? No, not at all. We have examples of people that have that. And so other you know, the most important thing is that we don't really, you know, one way to look at it is we don't really want to exclude any child from the potential of this treatment, which is relatively, to me at least, relatively easy compared to strong neuropsychiatric meds by arbitrary criteria, you know. So as long as it has those reasonable things, then I would consider it. Even chronic, I mentioned, you know, everybody knows that one amazing, you know, important characteristic of PANDAS is the overnight change, right? That the child is one child on Thursday and on Friday is a completely different child. That happens often, but it doesn't always happen, and the absence of acute onset is definitely, to me at least, not a disqualifying feature for PANS. It is in the, you know, according to the criteria, and if it ever makes DSM 6 or something, it you know, maybe that will be in the criteria. But in the real world, there are definitely kids that have a much more chronic course, and they can be treated and helped the exact same way as kids that get worse overnight. So this is all evolving. I mean, you know, we're learning more things over time, and you know, this is. But I think most doctors that actually treat patients would agree with what I just said. So, oh, a question. I'm sorry. We're trying. I apologize.
No, on the right, see Tammy.
On the right, Tammy. What does it? This is from Tammy Bianco. Thank you, Tammy. And Tammy, I know, is from North Carolina. Thank you. And what does it mean if for the child if they have PANS and autoimmune encephalopathy? Well, let's put it this way. PANS you can consider when it's in a certain phase is really an autoimmune encephalopathy. They're the same thing, you know. So autoimmune, but PANDAS, when it starts off, doesn't have to involve, you know, doesn't have to involve antibodies. And here we're thinking about the little 5-year-old kid who never had an episode of strep and then, or, you know, and suddenly develops OCD. That often is not autoimmune in nature. And as a result, you know, the simple treatments of ibuprofen and treating the infection will make it better. That won't be true, for example, with autoimmune encephalopathies. Just treating with simple anti-inflammatories like ibuprofen and infection, you know, antibiotics will not make them better, you know. So they require a real suppression of the immune system in order to get better. So it's certainly possible for a child to have both PANS, you know, have autoimmune encephalopathy related to PANS. How about that? That's a better way to say it. There was a Dr. Finn Somnier, a very, you know, sort of a colleague of Dr. Cunningham, who recently passed away, unfortunately, but who worked in Denmark, in Copenhagen, who used to call PANS to him streptococcal encephalopathy. That's the word he used. Maybe that's a better term, you know. But we think of it as something that evolves over time. So we have a chance to stop these kids from getting to that point. Whereas with Sydenham's chorea, they get the symptoms right away. Okay. Thank you very much, Tammy, for your question. I hope that helped.
Yes, thank you.
If anybody else has questions, what we're doing here now is just, I couldn't tell you how to do it, but if you can get on the chat line, just type in your question and we'll try to answer it. How about that? We'll see if that works. So if I'll maybe try another question that somebody else had as well. Article, okay. Any links between autoimmune deficiency and skin conditions? Well, okay, that's a hard one to answer. You know, certainly we know there are some autoimmune diseases that manifest with skin findings, you know. So, for example, one of them is psoriasis. That's the one that immediately comes to mind. There is a form of psoriasis that is strongly, it's thought to be an autoimmune disease. There are certain different subtypes of psoriasis, one of which is called HLA-B27 positive psoriasis, or psoriatic arthritis. And there is a form of psoriasis that's called nummular psoriasis, N-U-M-M-A-R, psoriasis, and that's strep associated. Okay, we have another question. Hadley, where are you located, Hadley? I'm sorry, I've forgotten. Hadley, where are you? You're in. Where are you located?
I'm in New Zealand.
Okay, great, fantastic. Wow, it's like a little time delay because of the speed of light. I think it's amazing, right? You know, 100 millisecond delay. It proves that Einstein was right. Okay, so do you see children with these conditions growing out of symptoms after puberty? My son is 13 and hasn't had a flare-up for 2 years, and absolutely, that's the interesting thing. It really needs, the natural history of this condition needs to be studied. So we don't know yet. People ask me, like, you'll have a first time PANS, a kid that is 7 or 8 years old, first episode of OCD. Everybody has the same question, like, what can we expect from this in the future? The answer is, the right answer, the honest answer is, we don't know. Because to know, we would have to take 100 such kids in some sort of study and then follow them for 20 years, and that takes a long time to do right, and probably would take, several centers to do it properly. And we would want to follow them and learn how many of them have just one episode, how many of them have more than one episode, how many of them end up in mental hospitals because of their episodes, and how many of them get better. And, we can only answer that question informally, like, based on our impressions of things and what we have done, and maybe we could get some retrospective view. So what I'm telling you about there, that when we follow people, that's called a prospective study, where we set the experiment up and then watch what happens, versus a retrospective study is, let's look at the charts people we've already seen and go backwards and look to see what they have. And of course, the problem you have with when kids get better is they don't bother seeing the doctor anymore when they're better. So you never really know. If you've got good contact with a patient, I'm always very happy to hear from people of mine that have gotten better. Tell me, Dr. Tripoletti, I got better, so I know that that's just another good thing to know about, because that gives us just another thing. But it's not a study, but it gives us an impression. The answer is yes. That's what's commonly quoted. What you just said there, better at puberty, is definitely reported. It's for a long time for Tourette's syndrome, right, for tics, and to some extent OCD. And so I think the early type of PANDAS, what we call the typical common PANDAS, which I call the Swato syndrome, with the acute onset of OCD and tics, seems to get better at puberty. And amazingly, we also see immune changes at puberty as well. Infections that a child could not clear as they go through puberty get better. And it's not exactly puberty, I think. And I don't think it's specific to girls or boys. It's the same in both. So I doubt if it's testosterone or estrogen mediated. I think it's more complicated than that. It seems to get better really when the growth phase stops, when children stop growing. And you can sort of tell that by, just looking at their height. But another biochemical clue you have is an enzyme called alkaline phosphatase, which is in the routine chemistry panel of most places. And alkaline phosphatase, most of it is found in bone, and specifically in osteoclasts and osteoblasts, cells that break and remodel bone. And what do we do? How do we grow? I mean, our body, one thing definitely, if we, when we grow, is our bones get longer, right? That's how we get taller, is because our skeleton changes in shape. It certainly happens very quickly until you're about 15, and then it slows down a lot, and there are different phases, and a little different from girls and boys in terms of the way the hips look, etc. But the skeleton is remodeling or changing a lot, and then sort of stops. When you're 20, you don't grow anymore, and your skeleton, until you get very old, doesn't change very much in terms of its shape. And in fact, it looks like there's a difference in collagen, because what happens in bone when you grow, it's kind of interesting. It's very similar. I tell people it's very similar to if you wanted to put an extension on your house, right? And you're a bone growing. It's the way it works is you add more, a little bit more frame to the bone, but then you have to break down the wall to extend your house. So you have to build walls and break down walls to make your house bigger. So that's what the body is doing. And then after puberty, it stops. And it's something about that that's really important. And I think it has a lot to do with collagen and the nature of collagen. And I think that is in some way related to our finding of or suspicion that there's a relationship between collagen disorders like Ehlers-Danlos syndrome and PANDAS. But yes, it looks like it's real. And if that's true, it's very important because that tells us that really what we got to do with PANDAS is just ride it out till puberty, right? If you have an 8-year-old kid, what we have to do is keep them stable, keep them functional, keep them do what we have to do to, get them on track as much as possible, avoid infections, fix whatever immune problems we can, and get them to puberty, and things will get better, So if that's true, as I said, I think it's true, but we have to study it. Thank you. Another question, and I don't know quite, it says reply in private, so I don't know if I should, I guess I could, I won't, you know what I'll do here is I'll reply, I won't say who asked the question, okay, just so, in this case, I'm taking it to mean that you're the question that you want answered, but not necessarily your name used, so we'll do it that way. So can IVIG treatments make PANDAS worse? Unfortunately, the answer is yes. And that's very, if it's ever happened to you, it's disheartening, right? Because you've maybe spent the money out of pocket to spend $10,000 to $20,000 or some large sum of money on this IVIG treatment, and in fact, your child gets worse. I could say on average, this is not, again, like the other statement, a guesstimate, that about 80% of kids get better with IVIG. A smaller percentage don't. I don't agree. Dr. Kovacevic, who I greatly admire and respect, often makes the statement that IVIG is not effective after puberty, and I disagree with that. I think we've helped many children before and after puberty, so that's not the thing. When we have the unfortunate situation that PANDAS gets worse, what do we think about if that should happen to a patient? Why did that happen? Well, the number one reason usually is that when we give IVIG, well, of course you could have the situation where you have an anaphylactic reaction or some sort of immune reaction to the IVIG. That could happen. That I think you would know about right away when it's going in. But sometimes children and children with PANDAS are apt to do this, are actually brewing an infection or in the middle of something, and when they get that infection and you give them immunosuppression at the same time, the infection gets worse, the child gets worse usually. So that corollary of that is we really do want to try, we don't, unless we're in extremely dire straits, we never want to jump into IVIG right away without having some sense that we've treated all the infections that we can, So we definitely do that. For example, if your child has Lyme disease and needs IVIG, treat the Lyme disease first. If your child needs their, you're debating taking the tonsils out and then doing IVIG, take the tonsils out first. Treat that infection and get that better before you give the IVIG, or you're liable to have a bad response. So I think most people that that do sort of what I do would agree with what I just said, that we have to the presence of inflammation needs to be treated before we suppress the immune system. Okay, another question. This is again an anonymous question. How important is targeting underlying infections or co-infections in treatment? we try our best to identify what infections we can. Now, the approach we take, and this may be changing in the next 5 years, I would say, is we have to do immune titers, right, to tell the presence of an infection. That's not a very, it's relatively easy to do, to screen for a lot of different infections, but it's not very satisfying because it's an imperfect way of looking at things. Within, I think, 5 years, we're going to have a technology to use DNA technology with ribosomal RNA sequencing, or PCR, of ribosomal RNA sequences to identify bacteria without having to culture them. So that's really exciting for our field, because we'll be able to take either a blood sample or sample a swab in the nose, and then actually get a really precise answer as to not only what species is there, but even the strain of a species that's present, so we can really understand that. Now, how important is it to be very precise in answering that question? I think not that important, okay? Because some of the treatments we give, will treat multiple things at once. So, for example, if we think a person might have a strep throat and they might also have Lyme disease, how important is it to establish they have Lyme disease? It's important, but not absolutely critical, because the treatment of the strep throat and Lyme disease overlap to some extent. So if you're not sure, so you want to use broad enough antibiotics to cover all the possibilities, all the reasonable possibilities. And that happens all the time in medicine. You get an infection, and I know people that have had personal experience with this with family members that have gotten an infection, and they don't know exactly what it is, but they treat it with broad enough antibiotics to cover all the bases. So that happens. So we want to try to get some answer, but we can't do every test known to man. There's just simply too many pathogens out there. So I usually use a common, a half dozen or so infections that are common, and that I could say like 80 to 90% of the time we'll get the answer, what's triggering a patient. But going beyond that is probably not too productive. Another question is from Vicky. I don't know who Vicky. I hope it's not my daughter Vicky. She shouldn't. I hope she's not watching her father. What is a good probiotic to use when on the antibiotics? Okay. Well, I think most of you in the audience know anything without Strep thermophilus in it, right? I mean, if you don't know what that is, let me just quickly mention that there is a bacteria named Streptococcus thermophilus, heat-loving bacteria in Greek, right? Thermophilus. Philo means love, like Philadelphia, the city of brotherly love, right? So philo. So thermophilus. It's heat-loving. Why does that matter? Because when you pasteurize products, you heat them up, but not to boiling, not to 212 degrees, to about 160, nice warm milk. That's kind of one of the reasons that they used to heat up your baby formula when you were little. So they were somewhat pasteurizing the milk. And most bacteria will die at 160 degrees if you keep the temperature up. The vast majority of bacteria, a couple of bacteria won't die. Those that love the heat, the thermophilic bacteria and their friends, will survive. So that allows you to make products that have bacteria in them, like cultured products, like like yogurt and kefir and things like that. You can pasteurize them and kill most of the bacteria, but still keep a couple of bacteria in there that are good for your gut. And that's what they sort of do. That's how you make yogurt, for example. And the probiotics are an extension of that, they're not, so if we try to avoid Strep thermophilus, I don't, have I ever published that anywhere? No, I wouldn't, other than keeping it on the, sort of in a place like this. I would not put it in the mainstream media, because obviously, if Dr. Tripoletti says that yogurt contains a bacteria that's bad for you, I'm going to have a lot of explaining to do somewhere. Somebody's going to want to hear about that, and I'm going to have to get, it's just not worth it. I mean, there are other choices. It's like, why take that if you have other choices that don't have the strep in it? I don't know if there's any way to do a poll on here, but it'd be interesting to see. One day maybe we'll do it on the Facebook page. How many people have had bad reactions to probiotics? I know I've heard of a few, but not too many that have that have had such reactions. But I still would recommend staying off that. So we want to pick a probiotic. Number one is one that is Strep thermophilus free. The other is that, if possible, pick a probiotic that that has a number of different strains in it. But even Culture L is better than nothing. The other important point, I think most of you know this already, but just in case, always give the probiotic away from the antibiotics. So at least 2 hours separated between when you give the two, so that there's no chance of the probiotic and the antibiotic being in the stomach at the same time. Okay. So another question. I can take a break in a little while. We'll see if we can have other, maybe other people can maybe make it more of a dialogue type situation in a little while. But two more questions. This is from Lori. I'm finding it difficult to get treatment for my young adult who has been suffering for years. Why is it so difficult for doctors who specialize in PANDAS PANS and autoimmune encephalitis? Why is it so difficult for doctors who specialize in PANDAS PANS and autoimmune encephalitis have such difficulty getting plasmapheresis set up for their patients? Okay, this is a question. Look, why do we? I know everybody in every country, no matter what state or what country you're from, have probably encountered roadblocks in treating this condition. Okay, and the people like myself that treat it are sometimes have to endure, humiliation by our colleagues, and like we're quacks and all that stuff, and it's challenging, So for all of us to treat this condition. The truth is, more advanced treatments like IVIG and plasmapheresis, while they are considered mainstream treatment for some conditions, are still not considered mainstream by either hospitals or insurance companies for PANDAS PANS. There are notable exceptions, like, for example, I think most of you know with plasmapheresis, the doctor in our field that has the most experience with that is Dr. Latimer in Washington, D.C. She's done the most cases and written papers on it. And she's able to do it because she has she's working in a hospital environment that's amenable to it, So for whatever reason, they're willing to cooperate. And a few other doctors but for the most part, for the vast majority of hospitals, they simply will not allow a doctor on staff to do plasmapheresis on one of their patients. And so that's just the way it is. I mean, you can't, now plasmapheresis, that's worth a whole nother, talking about that is take us way off. But just leave it be that it's a treatment that it's much more logistically difficult to pull off. You need to do it in an ICU. You need to have all the right personnel that know what they're doing with this treatment, that needs extensive monitoring. It's not easy to do. And so therefore, it really limits. You can't do it. I can't do it in my office here, on my own, like I could IVIG. It's just simply not possible to do that safely in that setting. So it always has to be done in a hospital, and usually a big hospital, and therefore subject to whatever restrictions the hospital wants to impose, which often blocks that happening. So I think that's the answer to the question, because they. There are logistical things in the way. Sometimes some doctors have arrangements as part of their coming on staff or being that they will be allowed to do these procedures. But short of that, it's very difficult. Okay, two more questions. If there are more questions after this, I'll turn it over. I'll stop and maybe we'll try another phase of this open forum. Let me stick with, and then we'll go to the other questions that people have. First, the last two questions. Can someone be a carrier of strep throat without an active infection? Will being exposed to them cause a flare for PANDAS children? The answer is, it's a simple one, I think. Yes. That's what a strep, what does a strep carrier mean? A strep carrier means that you're intermittently shedding strep and have your immune system sees the strep and you have elevated ASO and anti-DNA speed titers, immune evidence of strep, but you have no symptoms and you don't go to the doctor and you drink out of your water bottle and leave your water bottle on the table and your PANDAS-prone child then drinks out of the same bottle and gets the strep. So because you don't know you have it. Will being exposed to them cause flare-ups? Absolutely. So leave that be as it is. But that's what makes this challenging. And by the way, the other interesting thing about this, if you think about it, a lot of parents really get uptight and with their kids in school, and they get worried. They want the teacher to tell them every time there's one kid in the class that has strep. That's nice if they do that, but it's needless worry, okay? You have to assume universal exposure. You have to take universal precautions. Everybody could have strep at any time because of carriers. So just simply being, so we have to view it that way. We can't assume that we only need to deal with it when there's a child who's overtly symptomatic in a class, because there may be, that child may be across the room, but your child may be sitting next to a carrier. There's no way of knowing. Okay, the last question in this part of the talk is another anonymous question. Why are anger, rage, and paranoia symptoms of PANDAS? How can these symptoms be minimized? Okay, well, we don't know the real answer to that question. We just have a guess, okay? And here's the guess, is that the part of the brain, which I call the PANDAS center, in the hypothalamus, is hooked up to a part of the brain called the amygdala, the amygdaloid nucleus. And that is the part of the brain which, if stimulated, produces anger and rage. That's for sure. Paranoia, not so much, that's a more complex thing. But, that may involve anxiety and anger too, or defensiveness, a fight or flight reaction. Okay, so you can see how catatonia could happen. An animal freezes, a deer freezes, or a deer is worried that something bad is going to happen to him, is hypervigilant. That may be viewed as paranoia too. But I think it's part of the parcel of the connections of the PANDAS centers in the brain. Just like some connect to the striatum and produce OCD and tics, others produce the rage centers and tend to give you this picture. How do we minimize it? Well, treat the PANDAS. That would be one way to stop it. If we knew how to block histaminergic, H3 histaminergic neurotransmission in the brain somehow, whether it's by a drug or something, that would probably help too. Many drug companies are working on those drugs, but you could view them as just another psychopharmacologic agent, so that really doesn't get you very far. And I don't know really otherwise how to minimize those symptoms other than treating PANDAS as aggressively as you can. Okay, so do you want to? Why don't we do this now? We have some other parents here that came, and maybe they want to introduce themselves to the what? Actually, we have a water bottle, a 7-Up bottle. You can see that's our
We got
honorary.
Diane
Yeah.
Do you have any questions?
Okay.
One of my questions is on
Lisa,
the-
you maybe want to come
Hi.
get yourself in the.
I disappeared.
You disappeared?
You have to
Above
come
the
in.
camera?
There's Lisa.
Hi.
Lisa Bonzo.
One of the question I had is about the inappropriate sexual talk and, when it happens in school. I mean, it's bad enough at home, but what do you do? I mean, how does that, I know I watched one of your videos and that was one I made my whole family. I said, this is your doctor and you hear him saying this is a symptom of it. But how do you, especially in school, how do you go about that with the teacher?
Oh, I mean, that's very, very hard. That could happen. I think you're talking.
Yeah, like what? Yeah, I know it
Well,
I mean, yeah,
I think part of what we're seeing here is PANDAS is a subcortical condition. It's below the cortex. A lot of it is you don't feel, or the patients aren't able to describe exactly what they're feeling. So some of these things are, a lot of things that you see, for example, in Tourette syndrome, are primal rate, they're primal movements. They look like sniffles, OCD, which is anxiety, like an animal is scared of something. So you're seeing a lot of things that are very primal, very old. The lower down you go in the brain, closer to the spinal cord, the older you see things in evolution. And logically, the cortex is really, a late development in evolution. So you see sexual behavior. Every animal does it, so you'll see that. You'll see all sorts of crazy things happening in these kids, from just cursing, to, actual physically attacking the mother, and we've had cases like that, which are really, now obviously that some things, whether it's pandas or whatever it is, some things are completely inappropriate in the school setting. So, now they can be understanding, but, if you start saying the F word, every third word out of your mouth is the F word, whether you can control it or not, I mean, that's impossible. Kids are either the, it's going to disrupt the class. I mean, so it's very little. The teacher may be understanding that the child is out of his control, but whether or not it's in his control, it still can't be done, right? I mean, it's school in the regular setting. So we try to, those are, it doesn't necessarily be sexual. It could be something like a loud scream. I mean, something like that would be equally disruptive. So those type of things we have to stop. There are certain let's say that we're a tick. I don't know. Let's say a curse word pops out like coprolalia, which we get sometimes. We have to stop that for a kid to go to school. I mean, so by, so that means be aggressive, more aggressive in treating that than you normally would be. So it's not even though it might be the same part of the brain, and it's very hard to tell the difference between eye blinking and cursing like that, still one is socially much less acceptable than the other, so you have to stop it. If your kid's going to go to mainstream school. And sometimes he can't, and you're stuck. Is that the question you had, or more like how, now?
No, I mean, because it happens at home, Mr. Nick, but I know that I know there are kids which have the behaviors in school. I see it all the time with parents going, what do I do? And the teacher, and they're calling diapers and that type of thing. When they're talking about body parts and,
yeah, I mean, because that's the logical thing that they have to understand. I can see that where kids they're assuming, they're seeing a kid who's talking about, and the amazing thing, I don't know if anybody has experience with this, you can get a 5-year-old kid and they can talk about like the most like far out sex that you could ever think of, and you say, where the heck did they get that from?
Yeah.
And it's there, it's built into your brain somehow, I guess. I mean, that's the only thing I can think of. It's
previous life.
Yeah. No, yeah, maybe a previous life. I don't know what it was, but I mean, it's like it's there in your brain. So you didn't get it from SpongeBob, But when people hear this,
I know.
I don't think, But when people hear this, like a 5-year-old talking about anal sex, they say like, oh my God, this, the person you think of is like, this has got to be like, yeah, what they want? Somebody's doing something to them somewhere, right? Because they would never know about that unless they had a personal encounter with it. See, so, but unfortunately, it does happen, and we invest. When you finally know the family and know the situation, it isn't happening. They aren't being sexually abused. It's a difficult situation, and people are going to have, maybe diapers will get to be called, and they have to be educated. Hopefully, I haven't had a kid that happened, that scenario where they're taking a kid away because of a situation like that. So anyway. There were other questions that people had.
They emailed those in.
Yeah, some were emailed in, so maybe we'll handle those. And I don't know if there's any way to make this more like dialogue type thing, because I'm just like talking to people. I don't mind,
Does anybody have any questions?
They're emailing the questions.
Oh,
Okay.
does anybody want to speak in?
I have a question.
Sure.
I keep reading about how different parents change their child's diet, like gluten-free, dairy-free, how these things cause inflammation. Is it totally necessary? Because like my daughter is so picky. So, that seems like it would be very stressful. It's something we want to try, but stress also, right? Like, so where would you begin in that
In a general way, okay? So in a general way, inflammation from any source is going to make this worse, okay? And that's true of autism and many conditions of life. So you got to think of that as a component to the thing. So there may, you gotta say, pick your battles. How about that? So that might be a good way to look at it. Like, in certain situations, like if you're dealing with, an older person and they're, or they're not, it's an only child, maybe doing a gluten-free diet is pretty easy. But if you got a lot of little kids running around, it's really hard. It's really hard because you have to really, to do it, the whole family has to be gluten-free. That's a big commitment. Not just money-wise, it costs about 3 times as much, but you can usually get the things you want, but it's hard. So, because of course the little kid they see their brother eating an Oreo and they want the real Oreo and not the gluten-free Oreo. It probably tastes, I don't know, I've never tasted them, but they probably are pretty similar. So it's hard. So that's what you have to go through to get a kid. Now, obviously, if a kid's picky eater to begin with, you got to think calories. Where the heck with the gluten? It will do something else. Some kids, gluten's dominant, right? I mean, the gluten is a major problem, and you have to focus on that. We have, I can think of a child that we, that we treat we discovered had celiac disease. That was a whole, that solved a lot of problems, but they, were managed by GI. That kid had to have it, but he had antibodies. He had, at that point, So there really isn't it's whatever you can feel comfortable with. Obviously, now what are high inflammatory foods? High histamine foods usually are the things that do that, they are usually, many of them are foods that make sense, like, things that are very spicy, right? Which, than pepperoni pizza, kids usually don't eat too much of that, like, I don't know, maybe they do, tacos, or, they're a little older, maybe they do, so they eat some of those things. But the things that really, kind of makes it, if you absolutely have to have those foods, one thing that's a good thing to know about is this stuff called histane, which is histame, histane, which is diamine oxidase, an enzyme that breaks down histamine. So you can, it's like Beano, basically. You take it when you eat some refried beans, so you don't, but it's an enzyme, basically, that allows you, right, Mary? So.
Yeah. Can you say what that is again?
It's called histame, histame, and it's available. You can see it online. It's an enzyme that you take, and if a child has to eat a very spicy meal, it will reduce the amount of histamine that's produced because by degrading, So that's good,
So is that something that would be good to just go ahead and give a PANDAS child or a child with allergies and asthma?
I think so. I don't think there's any downside of it. It's really it's like a digestive enzyme, but it's a special one to lower histamine. Some of the digestive enzyme products, and there's so many of them, just like with probiotics, they may have that in there in combination with other things. But there is that one product that just has that. So that's good to have in your pocketbook just in case you're at especially if you're on vacation or something and you might be eating some pepperoni pizza or something like that, and then, that will help you out without making the kid flare from the food, so.
That was one of the questions. Was
Role of histamine.
How to treat it.
Okay. Sexual, okay, that was on there too. How the PANDAS child affects the family. Oh boy, that's a big one. That's a tough one. Each one of these things really require a whole session, right? But that's what it's good to have this too. To just that's a huge part of the problem, isn't it? I mean, for most people, depending on the severity. For the mild cases, eye blinking or some mild OCD, not so bad. But once it gets to the point where the behavior gets impossible, then the whole family is affected. Many kids with OCD it's very difficult for them to tell you what they have OCD to. And we hear parents saying they are walking on eggshells right there. They're not sure what to do. I mean, what do if they knew what to do with the kid, they would do it. But sometimes, I've heard parents say, they give a kid a day on Monday is craving a certain food. The next day, the mother, seeing the kid enjoyed that, finally gives the same thing, and the kid pushes it away, literally. So it's very hard to predict. So that's one aspect of it. Obviously, kids are violent too. That's that's the most worrisome thing. I had a patient, in the not too distant past, that is actually taking their non-PANDAS child for therapy because the PANDAS child has been beating the hell out of him for 3 years, that the kid has developed post-traumatic stress disorder and is actually sleeping in the mother's bed because he's afraid to be away from the mother with fear he's going to get beaten up by the PANDAS child. So, all sorts of permutations of these things. We've had kids that have extreme situations where children refuse to enter their house. There's something about the house that they don't like. So I actually had a person who owned a house who had to rent another house in the same town to so the kid could go there. So craziness, all this stuff.
Mom lived in one house with the kids. Dad lived in the other house with the other kids.
Yeah, I mean, it was craziness, yeah. So how does that affect the family? Tremendously. I mean, so, and there's all sorts of, permutations of this. So, this is very important. How to manage a flare? What do we do? I mean, with that.
Yes.
What I say is, and I think people that, I can see a number of the people here have been my patients, so this may be repetitive. Think fever, alternative fever response, if you don't, I think if your child had a temperature of 104, you would instinctively know what to do, right? It's you can't reach the doctor and the child has a high fever, what do we do? You call the pediatrician, right? No, you can't reach the pediatrician, right? So, that's, emergency room. Okay. But you're in, you're in, make it hard. You're on the moon or something. Okay. Yeah. So, all right. You're in you're in off the coast of New Zealand or something. Yeah. No, that's actually.
Lisa, tell us your story. What was it like?
No, but I mean,
that was bad.
what do you do? I mean, a situation like that where you don't immediately call a doctor. The answer is treat a fever. So the first step, if Motrin, right? So for any situation, there's no reason to believe that Motrin won't help PANDAS somewhat in any phase. Now, I often ask parents, like with these extremely violent kids, how the heck do you get any med into these kids? That's a good question,
Well, I tell Susie it has the patches now with cream.
Hey, tell us about that. That's important. This is
Find a compound pharmacy.
okay. One trick that people have is they're able to put ibuprofen, I guess, in patches. Okay, so you can just slap it on your kid, in their back or whatever, in a raging kid to get that in if you have that situation. That usually will help. Don't be afraid you'll use a little higher dose sometimes. So a patch and a half rather than one patch for your kid. Have them available. Bring them with you in your, on a trip with you if you have those things. That's helpful to get you out of a jam, And just like a fever, okay, you brought the fever down. Now you calm the kid down. Now what do we do? If this goes on, if it lingers on after the Motrin wears off, we got to find out, this is not just just a meltdown or something. This is a flare, it's longer lasting. So that usually means we got to treat it like, the same thing if you had a fever for 4 days, at a certain point, everybody, a fever lasts longer and longer in your kid, unexplained. At some point, everybody's going to see the doctor, everybody has their own threshold for it, but it will be see the doctor. The doctor will look at the kid and assess, is the kid, very sick and needs to go to the hospital or ER, or can I just kind of look in the kid's ears and listen to their chest and have them pee in a cup and try to find out where the infection is. And he doesn't isolate the bacteria. They just say, okay, you have an ear infection. And they know ear infections in your part of the world are caused by such and such bacteria, and a sufficiently broad amount of antibiotics will kill all those bacteria. So you have a very high chance of being successful in treating it with just that. They never really isolate the bacteria. So what you do here is in the PANDAS world, the equivalent to that is to don't do anything, just try to keep the kid calm. If it's a short flare, you manage it that way. If the child's on antibiotics, on prophylactic or low-dose antibiotics, increase the antibiotics. Call us at that point, when the child's in a PANDAS flare. We'll help you through it. Maybe at a certain point, probably about a flare that's particularly bad or not getting better and starting to affect the child in school, etc., it may be time, especially if it hasn't been done recently, for blood work and tests to try to find out what the cause is. And then we can get with a more, could be you're on antibiotics and the child has a big flare on antibiotics, and that threw us for a loop when we thought that PANDAS was only strep. Like, we just get on the strongest strep antibiotics and yet they're flaring. What's going on? Could it be a resistant group A strep? No, it's another infection. And you have to find out what that infection is to treat it. So that's the short answer. So there's an immediate thing you can do before calling the doctor, and then something after it lasts a long time to get involved. And your own doctor hopefully could be involved in that too. Maybe they would find an infection as well.
Restrictive eating was a topic a lot of people want.
Oh, okay. So, well, let's talk about, this is something that I know maybe you've heard Dr. Suedo say. There are really two big PANDAS emergencies. One is, most people would say, number one is restrictive eating, or not, when I mean not taking enough calories in, starving yourself, right? Happens in both girls and boys. It's not, almost never, body dysmorphic disorder. It's not that way. It's not, although I guess that could be exacerbated if that was part of your symptoms. And it's usually something of, either something about the food, the eating process. Either the food is dirty, the food makes my mouth feel funny, I swallow the food and I feel like something gets stuck. So the variety of symptoms that, you could have. But it's usually around anxiety and OCD in some way. So that's one emergency, is not eating. And the other is the kid doing dangerous things to himself or others, by which I mean running into the road, worrying, talking about hurting themselves, etc. Then you don't play any games. Yeah. I'm sorry?
Erica have anything she wants to ask?
Oh, sorry.
Erica?
Anything, Clay? No?
No?
Okay.
Do you have any questions?
I have a million questions. But when you get here, you forget. So the next time I'm writing a whole list.
Just email me tomorrow.
Well, here's a question that might be, all right, so do you see catatonic behavior with PANDAS?
Yes.
That's a good one.
That's a good one.
Mhm.
The answer is absolutely yes. And we have a number of patients with that catatonia, meaning, just complete lack of motion, not related, total ability to move, but no movement. And so the patient looks like they're stuck in a statue, often in a funny posture of some sort. Not always, but sometimes in a funny posture.
Is it more prevalent in boys than girls, or either or? Does it matter?
You know what, I don't want to say this, it's just an impression. I think people have done studies. I don't know the answer to that question intelligently. See it in both, though. Absolutely, you can see it. And I think, it's interesting about catatonia, a recent development. They showed that when a deer, you ever see, a deer in headlights, or an animal that plays dead or freezes, and they see you, it's an extreme form of anxiety. Try to pretend that I'm not there. If I don't move, maybe you'll run away. That type of thing. That's part of the fight or flight reaction. That's the third option, I guess, is freeze, flight, flight, or freeze. And, the part of the brain that does that, not the amygdala, but actually the basal ganglia. And what they showed in this beautiful study is that an animal that does that is actually undergoing the same phenomenon that a Parkinson's disease patient does when they freeze. And that's a well-known thing in Parkinson's disease, that they suddenly will freeze up. They'll be walking the road and then they just can't move. And that's maybe related to, the basal ganglia with the catatonia in that situation. So yes, here's a good question. What is a good way to contact you when you are not at an appointment?
Unfortunately, Dr. Trifoletti is not available 24/7, and call the staff during office hours. It's an emergency.
Yeah, so best way is, we do monitor emails frequently, where we don't have, every practice is different. We don't have an answering service. Believe me, we monitor emails frequently. And if you have an emergency, just number one, if it's an emergency that you think I can help you with, and you're close by, maybe we can make an appointment. But if it's an emergency that most likely if you're far away, gotta go to the emergency room for something like that. If it's something that can wait, we're here in the morning. Yeah. And then there's also your pediatrician that should be involved. We're not pediatricians, we do a specialty thing. So if your child has a a blocked tear duct or something like that, we're not, rash especially. It's very hard to diagnose these things over the internet. It really is. So that's not a good idea. Okay, have you treated parents with PTSS? I guess not, because I don't know what PTSS is. So post-traumatic. Okay, post-traumatic stress syndrome. Have I treated them? No, I mean I don't treat. I don't treat adults, but parents especially.
Like
but also, that would be psychiatry. Yeah. Do I have post-traumatic stress? Yes. No, I mean it's battle fatigue, right? They used to call it. Actually, it's very interesting. That's where it was. There's a guy at Hopkins who came up with that idea, battle fatigue. Yeah, well, it's pretty obvious. I know a lot of parents describe this, and that's as part of the thing. Yeah. Okay, seizures and immune deficiency. That's not CVID. How it links to PANDAS? That's a good question. I think, and this is, again, an impression thing, that how many, we know that if we just take 100 kids, there are going to be 1 out of 100 that have recurrent unprovoked seizures, which we call epilepsy, right? And however, it seems that among the PANDAS population, it's about the same. So I don't think there's a much higher incidence. It might be slightly higher incidence, but not a much higher incidence of seizures and PANDAS. Seizures and immune deficiency, if I saw a child with immune deficiency that had a seizure, I would send them right away to the emergency room and get them evaluated, because they would, depending on the type of immune deficiency, they could have meningitis, and that could present that way, and there could be other things, or encephalitis. So it's not a joke. Now, that being said, we get movements in PANDAS, like the catatonia is one example, where the child suddenly stops moving and they're staring, maybe as part of that movement. And that happens, staring spells. They're almost always not, by traditional means of assessment, they're not seizures, okay? Well, the word the words are important here, semantics. Then the word, what's a seizure? A seizure is any behavior, and it's actually Ewings-Jackson came up with a definition for this, but any behavior, be it motor, autonomic, or sensory, that is associated with in a cause and effect fashion with an abnormal or excessive EEG pattern, or electrical cortical activity, by which today we mean EEG. So you have to have, it's cortical, right? Does that mean that there are no neurons just underneath your cortex that can't fire and seize? Of course not. I mean, that's ridiculous. The EEG only really looks at the quarter-inch, half-inch below the skull, and that's it. That's just the cortex. So everything else, the basal ganglia, all that, the brainstem, and all that, is silent to the EEG. And you can assess it, but you need depth electrocorticography, which is insane to do in otherwise healthy kids, to assess that. So it's very hard to tell. But certainly there are kids with PANDAS that look like they're having seizures. Now, there is this thing that I think most of you have heard of called the exorcist syndrome, where it looks like a child is becoming possessed by something. They suddenly change state and they look dissociated and they are violent, and it looks like somebody else is in their body. Their pupils are dilated. It lasts for, minutes, maybe hours, a little bit of a tantrum, but it's not a permanent state. It stops. And it looks like a seizure. Could that be some sort of seizure? Well, we studied a number of patients with that. We've never seen a consistent, finding of epilepsy with that. So it's not a cortical event. It could be a subcortical seizure. There's no way of knowing at this point. There are ways of knowing by actually capturing these episodes in the presence of PET scan or other ways looking metabolically at the deep parts of the brain. There are ways to find out, but it's not easy. It's something that you have to have a study to do that. So the lowdown is we don't think there's a strong. So if you see a child with PANDAS that has a real grand mal seizure, you can't assume that that's just PANDAS going on. There's something else going on. We did have a patient like this that had intractable seizures and PANDAS, together. And it turned out the intractable seizures were something very different. It was something very fundamentally wrong with their genetics that popped up. It had nothing to do with PANDAS. So just for the future, just to mention that we're going to be talking in March about homeschooling, I guess. Is that right? Homeschooling. So maybe we'll try to find a way to make this more give and take, because I'm just doing all the talking.
If there was,
Yeah.
had the faces were on the cameras, I think it would be better.
They can't talk, and those
Well, they
people?
can. They don't have mics.
She's the only one that's faked and
Yeah.
everybody else just.
Everyone
Called
else
in.
called and.
I see. Okay. So we might have to set it up in such a way that they can all call. We can get people to talk to us. If anybody out there can talk, let us know.
I have a question.
Who is that? You can just say your first name, sir.
This is Allison.
Okay, Allison. Go ahead. I'm sorry.
Is it, so my son presented with PANDAS on April 2nd of last year, but ever since then, and he only got on antibiotics in June, but ever since then, he's never had a fever, never had a sore throat, strep, or anything. And just as of the last month or two, he has had sore throat and fever twice. And I think they were 2 times that I kind of tried to ease off of his antibiotics, and I was trying the Haley's Hope and some other things and trying to see if we could wean him onto other things. So I feel like every time he comes off of antibiotics or gets the dose lowered, he ends up with fever and a sore throat. Is that typical, or does that mean I need to be taking
unfortunately, there
some
are
other
kids that seem that seem exquisitely dependent on antibiotics or on Motrin or some other thing, or anti-inflammatories. That seem what they usually that means, when that happens, that they stop the antibiotics and they get an infection. It usually means there's immunodeficiency. In other words, so the antibiotics are a crutch. I would say they're not the cure. You need an intact immune system to clear infections, or good immune system. The antibiotics help you. They reduce the number of active. So I think usually, I'm sorry, Mrs. Boyd. Go ahead. Go ahead, Mrs.
No,
Boyd.
it's okay. I was going to say, I was looking for my next step to be getting his tonsils out, and then looking into IVIG after that. And I know we talked about that in our appointments, but it's that, does that seem like?
Yes. Yeah, in a general way, it's hard, to know. Yes, the answer is yes. Deal with the infections first, right? So I'm forgetting, with your son the details, but if he had frequent strep infections as the main or only thing he had, then yes, tonsillectomy would be a good thing to evaluate. And then once that's done, IVIG would probably be more effective than it would be now, so.
Okay, and they can do the tonsillectomy. They don't need him to be, he can be on the antibiotics and getting it. Like somebody asked me, he needs to be infection-free before he can get the tonsillectomy. And I'm like, well, he's on the antibiotics. So
what you're talking about there is you have to sterilize the tonsils. And, there's a protocol that we use to do that. And I think, it's, I'm not really, so you can.
Yeah.
Yeah.
Okay.
All right, good.
Thank you.
Okay. If someone has a child with OCD and anxiety that flares up from time to time and goes away, is it advisable for them to try Motrin to see if symptoms improve? I would say yes. That's a good time to try it. That's Motrin is a mild and readily available treatment. You don't have to. In every country I know about, you can just go and buy it at the pharmacy. You don't need a doctor involved necessarily in the loop. How long to take Motrin? I would say, no more than 10 days, I would say. Depends, just in a general way, all right? Obviously, we had a child where there was a concern about kidney disease, pre-existing kidney disease in the child. We didn't recommend Motrin at all. That's the main toxicity of it. Or if you have a child that has any issues with GI bleeds or a coagulopathy of some sort, or maybe taking other blood thinning meds. We had a child, who had a history of a stroke who was on Coumadin, for that to prevent the stroke. And we couldn't use ibuprofen in that setting. So, but the general answer is yes. Now, there have been weird, and this is exciting, that in certain circumstances, people have found when they give their child Motrin or treat the PANDAS that they end up better than they ever were, which is always exciting to hear that. And that usually means that they've had some underlying low-level inflammation that has always been present. Okay, this is a anonymous question. How do you handle C. diff when the child needs antibiotics? That's a tough one, but there is generally a protocol for that. And what's normally done is you stop the antibiotics that are present. Think of the C. diff as it's a source of inflammation. So you gotta, a lot of parents say, gotta take him off the antibiotics. Now he's gonna flare. Well, if the kid has C. diff, he's gonna flare anyway. So you gotta treat the C. diff. And generally, step one from in general is Flagyl, metronidazole or Flagyl is the first drug. Beyond that, if that doesn't work, vancomycin is the next drug. PO. You want a drug that is confined to vancomycin orally does not get into your blood at all, so it stays in the gut and it kills your bacteria that way. We try not to use vancomycin for obvious reasons of the chance of increasing MRSA infection, methicillin-resistant Staph aureus. Vancomycin is or vancomycin-resistant Enterococcus too. So there are certain, we don't want to use that drug easily, but there are ways of dealing with it. It's definitely a setback though, so so we surveil kids, every so often.
Dr. T,
Yes.
you mentioned MRSA. Is that a common infection that kids with PANDAS have, or just with autoimmune disorder in general?
Yeah, I think yes. The answer is yes. There's no reason to think that MRSA can't do it. Or Staphylococcus or any bacteria in general, might be doing it. So the problem is it's not too easy to document it,
Well, if say for example, like they already have been diagnosed, but then now they're starting to get MRSA infections, is that, could that be correlated just because they're more susceptible because they have autoimmune deficiency?
Yes.
Or is there some sort of tie with PANS and PANDAS?
Well, probably, it depends on the specific situation, but there definitely are parts of the, the immune system that are important in MRSA, like, for example, mannose binding lectin, etc. So they may have other issues aside, because you can have PANDAS with or without significant immunodeficiency. That makes it harder.
Right.
So kids that have MRSA, and the truth is, the testing we do, or we can do for the immune system, is the tip of the iceberg. We measure antibodies. Sometimes we measure mannose binding lectin. Sometimes we measure T cell function. But that is, there are thousands of genes that are involved in the immune system. And really to understand the specific, we had a kid, not too long ago that had looked like they were very, very susceptible to viral infections. And specifically had problems, and with that, and as a result, and the testing didn't show anything, but we know there's something wrong, and somehow in their mechanism. So anyway.
Okay, so and you're saying too that could also be the cause of, even if it's not because of PANS or PANDAS, it could, in addition, that could be a bacteria that causes a flare.
Oh, absolutely. Yeah. No. Pretty much a good rule is anything that can potentially cause a fever or an infection that can cause inflammation on your skin could produce pandas, if it's severe enough. So there's nothing really that's ruled out. Sometimes you see dental bacteria. We'll hear, actually in April, we're going to be hearing about the dental aspects of it, which comes up a lot. And maybe we'll talk, at some point we can bring an allergist in here to talk about allergies, maybe in May, in allergy season. Oh, we have somebody lined up to, good, yeah. All right, so I've been told by my boss that I'm only allowed to have 2 more questions, so here are the questions. What if strep this is a good one. What if strep is hiding deep in the brain or somewhere where the antibiotics can't reach? Well, strep doesn't hide deep in your brain. Hopefully there are no bacteria like strep in your brain, because, why is that? Because if they were in your brain, you'd be damn sick, and that's meningitis. This idea that strep attacks the brain is not right. I mean, that doesn't happen. I mean, not in this. It does happen, but you'd be a lot sicker. It wouldn't be something that would be smoldering like this. So how about if it's someplace else? The other part of it is somewhere where antibiotics can't reach. Problem is we can't tell. I mean, where's the strep hiding? It tends to hide. Where do we find strep? It really, when we talk about strep pyogenes at least, it lives up and down the GI tract from mouth to anus, and is drained by lymphatic vessels and nodes that drain the gut, basically. So you can be thinking in a general way as a nasopharynx, as the pharynx is really part of you breathe through it, but you also swallow through it. So, the mouth. So, you consider it part of both the GI and the respiratory systems in some sense. So yes, infections of the mouth are part of that, and that it lives there. But also in your gut, as you go down into the ileum and the jejunum, the duodenum, the jejunum, and the ileum. Yes, you can find strep there, and it manifests as in the appendix, which is a large, basically like a tonsil of the colon. If you could, the ileocecal area is this big, bit of tissue there. That also commonly is affected by strep. It's been said that the 3rd most common bacteria isolated at appendectomy is strep pyogenes. So it's hiding there in a sense. We can't tell though, So that's why you have to use a special antibiotic that can reach it. Generally, the best antibiotic to treat strep is clindamycin with rifampin. That's been the gold standard for years, And so sometimes we will use that protocol when we really want to get all the strep we possibly can as deeply in the body. So that sometimes is part of the protocol we use for pre and post tonsillectomy. Okay, one last question I have. I've been told that they're going to let the Dobermans out now, or yeah, please. Yes. Oh, Yorkies. Oh, yes. The teacup Yorkies are being let out. Lucia and her friends. We continuously talk about my son's sinuses, and we are aware he has high levels of environmental allergens. Would it be beneficial to desensitize him from his allergies? This involves giving low dose of an allergen. So would that trigger an excellent question, right? Okay, comes up a lot, because we know. All right, so you've been able to determine that your child is allergic to an array of things, right? If it's sometimes it's the most of it, 90% of it is one thing. Sometimes it's a peanut, or it's cat dander or something like that, depending on the situation. The obvious thing there is get rid of it. Step number 1 is remove the allergen if you can. Now there are kids that test. Sometimes you can remove the allergen. Like even a cat, I wouldn't remove the cat because of any allergen. Never. A cat or a dog. Well, maybe a dog. I don't know. But whatever it is, you wouldn't. There's certain situations where it's almost impossible to eliminate an allergen. So then you can desensitize them. Now, on the other hand, if you have a kid whose IgE is 2,000 and they're allergic to the world, everything, that you can think of, that desensitization won't work because there's too many things to desensitize to. But if it's primarily one thing, then that can work. in my experience, and I really would want an allergist that really does this all the time to tell us more about what this involves and the mechanism of action. This is not comparable to a vaccine. This is subcutaneous, low dose of allergen. It's meant to develop a very specific minor IgE mediated response, not to stimulate your body to do a massive, a T-cell programming for like a vaccine would. So we really haven't had, and maybe people out there could say otherwise, but in my experience, I haven't seen any patients flare from allergy shots. So I think you're okay doing that if those are recommended. And certainly, though, as I said, we'll try to get an allergist on a session to talk to us more about that, so. Okay, that's going to be it for tonight. Thank you very much for your time. And this was we'll try to make these better as time goes on. Maybe we'll try to make it so more give and take. I did a lot of talking, and I realize that might be the case. We tried to cover a broad range of issues this time, and maybe next time out we'll try to focus on different things and things I can help you with. I can help you more with the scientific things maybe and all that, but behavior, boy, I tell you, I'm not, that's not my forte, and you really need help with that one, Next month? Okay, yeah, let's tell you a little bit about next month. Good, Lisa.
Oh, next month we're going to have someone that has a homeschool academy.
Oh, great.
And she does have, and she's also, I think she's an occupational therapist.
Is this that place in England?
This is a friend of mine who actually homeschooled her children and started several years ago with her and a partner, a homeschool academy. So she does have, multiple children that can't go to school for one reason or another. So I figured that's a good topic because a lot of these kids sometimes have to be homeschooled for a certain period of time.
I don't know if anybody would, also, I don't know anything about the laws of homeschooling. Is it allowed? Is that something that is allowed?
Well, she'll know. Yeah, she covers a lot of states, so she knows all about that.
Yeah, and they're different. The laws are different per state.
Yeah, that's what I would think, huh? And I don't know. Yeah.
Yeah, she's in New York.
Different than up north.
Yeah, she's got people texting.
Well, I could see like certain areas of the country that are much more, I would say more religious. Faith, certain areas, I don't want to make any stereotypes, but I could imagine certain parts of the country, there would be a lot more interest in that for religious reasons, and here we're talking about medical reasons. I would think that would be allowed almost anywhere,
Yeah, well, that's why I said she has people registered all over the country, so she'll know how to guide people. And then, like you said, in April, we have the dentist coming, and then you could talk about loose teeth and flares and who's got to take meds before dental procedures and that type of stuff, because that's a big topic that comes up a lot.
Anybody has any other topics and suggestions, feel free to reach out to us. We'll give the consideration in the future meetings.
Yeah. And then the allergist that I took my kids to, she did a paper on pandas way back for her thesis way back in the day. So, and she's right over here. She lives in Saddle River. And she's, and her husband's an eye doctor. So I'll see if I can talk her into coming. I know. So.
Okay, everybody. Thank you very much for participating, and we hope to see you in a month. Thanks very much.
Thanks, Dr. T.
Bye-bye.
Bye-bye.
Thanks, Dr. T.
You're welcome. Yeah. Bye. What?
Thank you, Dr. T.
You're welcome.